Could FDA-approved Vyvgart, efgartigimod alpha FCAB for intravenous infusion, or Vyvgart Hytrulo, efgartigimod alpha and hyaluronidase QVFC for subcutaneous injection help your adult patients? Explore clinical trial data and learn how to get patients started at vyvgarthcp.com. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. This month, we're focusing on refractory headache for Migraine and Headache Awareness Month. This is the first part of a two-part series on refractory headache. With me to discuss is Jennifer Robblee and Larry Robbins. So as you know, June is Migraine and Headache Awareness Month, and I thought it would be a good idea to focus on refractory headache this time around. And both of you have played or are currently playing a prominent role in the better understanding of this group of disorders and this presentation. And Larry, you mentioned to me that you actually started up the refractory special interest group. And Jen, you're the current section lead, and I know you've reshaped that quite a bit. So why don't you introduce yourselves?
So I'm Larry Robbins, Associate Professor of Neurology at Chicago Medical School and in private practice near Chicago. And a little over 20 years ago, started the section of the American Headache Society, the refractory headache patient. And we spent a lot of years trying to define refractory headaches, and we're still trying to define refractory headaches. It's gone through many iterations. I think we've gone farther in definition than in our treatment.
Well, I don't think anyone can argue with that. Go ahead, Jen.
So my name is Jennifer Robblee. I'm an associate professor at Barrow Neurological Institute. And as mentioned, I've been the chair for the refractory headache group.
We do need to better think about a diagnostic criteria when we're approaching people that have refractory headache. Of course, there's the secondary headache disorders, and we always need to look at that. But once we really are convinced that we're not dealing with a secondary headache condition, some people will say think secondary headache again. But when we're really thinking about refractory chronic migraine, I'm interested in knowing both of your perspectives on how to approach and diagnose these patients.
Well, when we look at our diagnostic criteria, it's gone through many iterations and differences. When I have a patient in the clinic, if I have 100 patients, we end up with 100 different ways to go because of about 25 inputs that we put into each person, their medical history, their headache history, their weight, their GI comorbidities, psychiatric comorbidities, et cetera, et cetera. And the refractory patients, I also tend to group them into mild, moderate, and severe using a scale for clinical purposes, also for research purposes. So if we know one headache patient, we know one headache patient. Everybody really is different, and comorbidities tend to drive where I go with therapy.
So when I talk about refractory in a headache patient, this represents probably 20% of the patients that I see in my clinic based on an audit that I've done of my own patients. And I use some of the more recent criteria that have been proposed. There are many, many different criteria that have been proposed. You see everything from 2 to 3 medications tried up to having tried all preventive medications with various scales and various, tiers of how you might diagnose this. So the criteria that I've most related to are the ones that came out by the European Headache Federation. This was published in 2020, and that was by Sacco et al. And basically what they did was they divided it into 2 groups. They took refractory migraine, and then they did something called resistant migraine. So they had 2 tiers of how severe these patients were. Refractory migraine were the patients where they had tried all the different categories of preventive medications, and despite that, still continued to have no response and be debilitated. Meanwhile, the resistant migraine patients were those who had tried at least 3 preventive categories and continued to not respond. And so that's how we then took a next step, because it's been proposed, but there's nothing in our ICHD-3, and we're already on the way to getting ICHD-4. So in terms of how we diagnose headache conditions, we need some updated criteria, and we really need to get these diagnostic criteria into our diagnostic manual so we can start to better identify these patients and hence study them. And so right now we've got a working group. Larry and I are both part of this, and it came out of the Refractory SIG. And we've got people all across the world. And so what we're trying to do is how do we put all these different proposed criteria together and use a Delphi consensus to try to really say what as experts do we think this means. So my personal opinion on it is that what the European Headache Federation is suggesting, where you have to have tried all the medications, that's a pretty good starting place to me, because I really do see these patients, and these patients behave differently than a patient who has tried just a few treatments, because sometimes I can get those patients to respond by the fourth or fifth treatment. But those patients who have tried everything, it doesn't matter what I throw at them, they do not respond.
Well, we've been struggling with the definition of refractory chronic migraine for a lot of years now. I do think that we shouldn't solely focus on preventives, but we should look at response to abortives as well. I do like the idea of a simple definition and also a more complex one for headache specialists and for studies. I've published in the past on two definitions, one for countries with access to almost all meds and one for countries with limited access. One open question is how many categories of preventives do people need to fail on? And does a failure include contraindications without actually having tried the drug? I do like using a refractory scale, separating patients into mild, moderate, and severe refractory. And I also have a separate scale for adolescents versus adults. I think it is helpful to take age into account. We have adolescents versus adults versus the old, say 70 plus, versus the very old, arbitrarily 85 plus. And our approach does differ for the various age ranges. Another issue is the role of disability and functioning. I've tried to make the case that maybe we shouldn't rely on disability or functioning in our definitions. And finally, the role of medication overuse headache. It's conflated very often with medication overuse, however we want to define medication overuse. And medication overuse headache tends to be a little bit overdiagnosed and poorly defined.
So we definitely have some work in terms of the definitions and the classification. And I think great point on health equity, because if you don't get the right treatments, your insurance is limited to certain non-specific treatments, and you have a lot of disability, you may just, by all intents and purposes, look like a refractory patient, but maybe you're not. And then the other thing is that, we're limited because it's kind of largely defined by pharmaceutical response, we're limited to the currently existing treatments and not so much the biology. I'll never forget one patient that I had that had like 30, she tried literally over 30 treatments and came to me, and I put her on one of the CGRP inhibitors and did not expect for her to be better. And she was like, better. She had headache-free days for the first time in decades. She still wasn't a big fan, but she was better, and it just blew my mind. So there are some limitations in understanding the biology of refractory headache.
I think talking about the biology versus the access question is really important. And it gets to one of the heart of part of what we're discussing when we're doing this working group to try to come up with the diagnostic criteria. If your goal for criteria are so that you can research these patients, ultimately understand their biology, and then try to find new treatment targets that we're not already using, which will ultimately treat these patients, then I do think we need to go with biology and not access. And so one of the things that we've debated using is probable as one of the diagnostic groups. And then patients who don't have access, be it that insurance doesn't allow them to have access, or they're in a country where they don't have CGRP medications, or they do not have onabotulinum toxin, that they may be refractory for what they can access, but they're not perhaps biologically refractory because they haven't tried some of our newer agents. Same for children. They may not be able to get a CGRP medication covered, but perhaps once they're an adult and they get on a CGRP medication, they will respond. So I do think that's an important point to differentiate. And I think it's interesting about that patient who did ultimately respond to a CGRP medication. My guess is a lot of these patients who we call refractory, it's because we haven't found their appropriate treatment target. And as we look and find new treatment targets, we're going to slowly piece away this group of refractory patients, because many of the patients who now respond to the CGRP medications likely would have been refractory before these existed. So I think that's an interesting evolution that we're going to see in these patients.
Let's talk a little bit about the comorbidity burden. And we do have some epidemiologic data to guide us, but not a lot. And so what is your sense of patients that have many comorbidities?
So I think as a general rule, I find these patients have more comorbidities. And it hasn't been formally studied. So that is an area that we need lots of study. In fact, anything related to refractory headache is right for people to jump in and do some research. But I do find more comorbidities, the more it is difficult to treat a patient who has chronic migraine, especially comorbidities that are pain-related, but it does not have to be pain-related comorbidities. But likely the more pain-related conditions you have, the more you do have central sensitization that's likely driving these processes, and the harder it is for us to treat. So that would be my general rule in terms of exactly which comorbidities are drivers and which ones are not. I think we'd have to borrow from research on other things like what's more common in chronic migraine versus episodic migraine. It's likely going to also be true for refractory migraine.
Regarding comorbidities, we have our medical comorbidities, particularly inflammatory conditions, and we have our psychiatric comorbidities, which certainly co-occur at an increased rate with chronic migraine. Bipolar, for instance, we have at least 8 to 10% of chronic migraine patients fit the overall bipolar spectrum, including the very mild end. And then we have central sensitization, which is a key in progression. We're dealing with dark or negative plasticity when we talk about central sensitization leading to headaches. And other co-occurring similar conditions play a role, including fibro and TMD and CRPS and IBS and chronic pelvic pain, et cetera, et cetera. So when we have multiple central sensitization syndromes, I think it drives the headache, they co-occur, and it, as Jennifer mentioned, it makes everything more difficult to treat.
Great. So I think I want to talk about the future of this work, but before I do, I want our listeners to get some real value out of this. So let's talk about some of the misconceptions when it comes to refractory headache, and then let's talk about some key clinical pearls that we all should take away.
Well, I think one of the first misconceptions is that these are patients who are over-endorsing, that they're exaggerating what they're experiencing. And I find it's the exact opposite with these patients. These patients are underreporters. You have to ask them multiple times for them to be like, oh, yeah, the daily headache? I thought, no, that's just like my normal headache. It's just this very bizarre world where people assume these guys are drug seekers and assume that they're just complainers, and they are not. There are going to be some patients that have worse pain catastrophizing and more anxiety or hypervigilance than some patients. I do think that's one driver, but there is definitely a large group of refractory patients where their response is completely appropriate for being in constant pain along with all the other symptoms that come with migraine. So that to me is the biggest misconception. I know that earlier Larry mentioned about medication overuse headache, and I think we're going to over time see a lot of change in our perspective there. Again, I think that's something that we way overdiagnose. I don't think it should prevent us from diagnosing refractory headache. A lot of these patients have medication overuse because they're in constant pain. That does not mean that they have medication overuse headache. That just means that they're using it often.
That's a huge area right there, because I just had a denial about a medication, and part of that, they wanted me to kind of go through the note again, and they wanted me to verify the patient doesn't have medication overuse. The patient did not, because nothing works for that patient was extremely refractory. But some of these better treatments are the treatment for medication overuse headache. So I love that misconception.
Those are my two biggest, I guess you could call them pet peeves when it comes to treating these patients, is that people just misunderstand those concepts.
Many of the patients, or almost all, are diagnosed with medication overuse headache, which certainly medication overuse headache is important, but certainly not in all the patients. As Jennifer mentioned, they don't tend to embellish in my experience. They tend to actually minimize symptoms, many. A misconception is that they may be drug seeking. They really are not. They're relief seeking, which is different. That it's a psychiatric condition. They may have their co-occurring anxiety, depression, bipolar, ADHD, but it's not really psychiatric. And that these are difficult patients. They're normal people with a difficult headache problem, but I don't think any more difficult than anybody.
Now let's get some clinical pearls. How can we better treat these patients? What are we missing? What are we calling refractory headache, but indeed is not?
So the first thing that I always do is readdress that they actually meet the criteria for what we're talking about. You don't want to miss a secondary headache. One that definitely has been missed in these patients who come out and look like the refractory migraine are the patients who have had a longer standing CSF leak, a spinal CSF leak specifically. So that if you have a patient who's refractory, go back and see when this all first started, did they actually have a positional headache? Because they could lose that positional aspect over time. And all of these patients at some point, in my opinion, deserve an MRI. If you're getting to this point of refractoriness, you should have some neuroimaging. Honestly, it's pretty rare they don't, but I did just have one about a month ago. Luckily, imaging was normal. But in some ways, you almost wish there was something treatable that you were going to find. But that would be the one that I've definitely seen missed. In terms of some clinical pearls for treatment, number one, at this point, you're looking multidisciplinary. So often these patients have concurrent cervicogenic headache. So are you treating the neck? I like to get physical therapy and consider injections for these patients. Often that helps alleviate part of the pain because you have some of it that's radiating from the neck. So make sure you're not missing that piece. These patients may have a lot of pain catastrophization or hypervigilance. And even if they don't, often they're mourning a life lost because their life is just not what they expected. And so ensuring that they have good support when you're able to access it, something like a pain psychologist can be great. And at the very least, giving them tools for how you cope with this daily set of symptoms. In terms of pharmacologic therapies, we have great guidelines. Make sure they've actually tried everything on the guidelines, unless they really have an absolute contraindication. If they have a relative contraindication, consider trying it at low doses and just going really slow. A lot of these patients I find have a lot of chemical sensitivities as well. And so just because they said they have side effects, consider where they might have first started their dosing. If their first dosing of amitriptyline was at 25 milligrams, well, maybe try it at 10 or even have them start with a half tablet. At this point, it's not a race to get them onto dosing. It's trying to get them onto something and have a long enough trial. You want to make sure the trials have been at least 3 months. Some of these patients probably deserve an even longer trial of medication. So make sure what you're really dealing with is refractory and not that they've just been undertreated, because that's a different thing. And then if you've really tried all the different categories, consider doing combinations of therapies, or you start to go outside the box and do N of 1 trials. And that's what I spend a lot of my time doing with my patients. In terms of what to use, you can look through the literature. There's a lot of things that have been tried where there's variable evidence. So for instance, verapamil is not in our guidelines, but we often try it. And there's even a study that showed that there might be some genomic that point towards certain loci that will make you more likely to respond to verapamil. So you may have a patient who could be a responder that you just haven't tried it yet. Another thing that we try, and again, it's a little bit more nerve-wracking because it can come with some risks and side effects, are some of the antipsychotics. So olanzapine daily is something that some of us have tried. And again, I've had some patients have some benefit there. We also have to start to consider, though, what benefit means here. I have patients where they have a 9 out of 10 headache every day. They might be happy with that drop to an 8 or a 7 or a 6. They're not looking for a magical 0 at this point. So you're looking for incremental improvements at this point. So you also have to consider what your goals of care are. Obviously, if we can get them to a 0, you're a superstar. But the first step is how do we get them incrementally better? And then keep an eye out for any new therapy that's coming out. They're not going to be eligible, unfortunately, for most of the clinical trials, though I would love to see that change in the future, that we actually have trials for these patients. But in the meantime, as soon as you're able to get them on new therapies, those new targets may be the difference between them being refractory and not refractory.
I think that is a very important point, especially the improvement and really understanding what their perspective is, because while one patient, one point is like wonderful and a difference between going to work and not, or enjoying your day and not, to others, it might not be worth the side effects. And so I think that's where that dialogue is really important. What about you, Larry?
Well, for patients refractory to abortives, I just try and find something that might help 30% or more. I'll revisit older meds that might have worked in the past. I'll use combinations of triptans with NSAIDs, occasionally muscle relaxants, and even sometimes butalbital meds, which are useful as long as you greatly limit them. Many patients have not tried injections or even nasal sprays. There are many home injections available, from ketorolac to diphenhydramine to orphanedrine. And occasionally low-dose steroids are the only abortives that help. I just try to keep people out of the ER. Other last resort meds do include the atypicals, olanzapine, quetiapine, and also sodium valproate or amitriptyline or gabapentin sometimes do help. The patients who are refractory to preventives, which is a good 45% of patients, I think, we want to make sure they've tried onabotulinum toxin or a CGRP med or two, or polypharmacy, combining 2 or even 3 of the usual preventives. We will try SPG blocks for anterior pain and occipital posteriorly. And when triptans have been the only solution and the only med that has helped, sometimes using frequent or even daily triptans are possible. I try to use the kinder, gentler, longer-acting narotriptan, for instance. Occasionally, for the right person with ADHD or severe fatigue, which is common, stimulants can help the headaches, actually, particularly for chronic daily headache with associated comorbidities. I still do use low doses of the MAOI phenelzine, 1 or 2 at night. Phenelzine has been left in the dustbin of history because of SSRIs, SNRIs, but it's useful for some people with atypical depression, but for headaches, I think it's safer than people generally believe. Of course, we'll revisit past preventives that might have helped. I do use ketamine nasal spray that compounded. We've done this for 13 years in about 140 patients. Occasionally, it does help headaches. I use a very low dose, but I do find ketamine much more useful for severe mood disorders. Sometimes certain muscle relaxants, maybe because they're helping sleeping, will help prevent the headaches. And occasionally I'll use memantine or low-dose naltrexone. My last resort used to be low-dose opioids, but I rarely or almost never start them on anymore. Patients, we don't want to get into the opioids, but there are patients, if they fulfill criteria, and it's a very small minority, they can do well for long periods of time on these. But because of the environment, the opioid crisis, we just rarely go there anymore.
To add to that, I have to echo that I've had some good response to low-dose ketamine as well. You can get it compounded as a nasal spray or as troches, which are like little lozenges. And I find patients who are refractory to most other treatments, many of them will have at least some degree of response. Again, it's not magical. It's not taking away their headache, but often they tell me it's the only thing that's giving them some degree of relief. And these are patients that you could also bring in for infusions. I have the occasional patient where they found the outpatient clinic, and every month or two get an outpatient infusion. So that is, again, at the more extreme end. Obviously, this is not for the bulk of patients with migraine, but when we're talking specifically about refractory migraine, I think that's a great option. Getting into phenelzine, I agree, trying these MAOIs are a great option. I do know of some of the people who have been in headache medicine longer than I have actually tried even combining it with amitriptyline. You obviously want to be careful you're doing both at a low dose, but like Larry said, these are actually safer than we think they are, to the point that you could actually do that small combo. So again, another consideration, like doing a daily triptan. Some patients have a great response to DHE, but once they've gotten their infusions and come off, the headache tends to come back. So there is methylorgonavine. Again, it's another one that's sort of fallen off the list of things that we use, but it can be very effective for the correct patient. The concern with it, and one of the reasons why it fell off, is that category of ergots daily use over time, there's some concern that you can get fibrosis, and that's like in the peritoneum and lung cavity and around the heart. And so you do want to do some monitoring. So what I do for these patients is up front, I'll get just baseline imaging, so like chest x-ray, abdominal ultrasound, cardiac ultrasound, make sure everything looks normal. And then I'll do a drug holiday. Normally we say 3 to 6 months. Most patients I find we do about 6 months. I've never had it come back that there's any fibrosis. For that specific medication, it's more theoretical. But again, it's something you're better safe than sorry, because we know some of the older ergots that was something real that did happen. But that's another medication to consider, especially in your DHE responders.
Yeah, I agree. It's nice to start thinking about out-of-the-box approaches for patients and keeping safety in mind as well. And for some patients that have been on treatments for such a long time, have minimal response, sometimes drug holidays may actually be warranted.
Not even just warranted, but some patients, by the time they get to you, are on like 5 or 6 different things. And they're like, my headache's a 9 out of 10 every day. You're like, so I don't think any of the medications are working. Why don't we wean you off everything and start fresh? And sometimes that's actually helpful. They actually feel better off of all of those medications.
Yeah, I think that's part of the issue with the numeric scale, that they say they're 20% better, but then that was a 10 and now it's reset somehow. So I guess speaking about just treating patients, but assessing their response, and that we can't always go by the numeric scale or the number of headache days. Sometimes we have to talk about function and how much more have you been able to do, which is not easy when patients are already disabled.
I like to use the stoplight headache diary because then people do better at telling you how they're feeling and how they're functioning than a number. A number is really tough. If you ever try to rate your own pain, I'm never going to give myself a 10 because I've seen patients at a 10 and I'm like, well, that's never anywhere near what I am. So I'm like, I'm a 1 or 1.5. But with a, green day, you could tell patients, okay, so I know you have a constant headache, but what days are you fully functional? And how many of those do you have? What days are you kind of slowed down? You're a yellow. What days are you in bed? Are you going to the emergency room? You're just non-functional. I want to know how often those red days are. And right now our goal is to get rid or reduce the red days. And I find that language works well with these patients who are telling you, I have a daily 9. You're like, all right, what do I do with that? Nothing I'm doing is moving that 9. But you might move those red days. And so there is a difference in the number and a sort of functional scale.
Yeah, and when we talk about that, I think that's when the biopsychosocial understanding, because so much goes into what a red day is, a green day, a yellow day. Sometimes it's less to do with migraine, and it might be also tie in other factors, family dynamics, traffic, other hormone states, for example, the side effects of comorbidity burden. And so it all matters. And I think is the point in taking the holistic perspective. I think getting the number down for me is my patients are trained to do that, and they get very good to the point that if I don't look at some people's diary, they can get upset with me. I think that holistic perspective is very good. So yeah, let's talk about who's at risk.
There's a number of risk factors for developing refractory chronic migraine. Allodynia is a marker for central sensitization and does seem to predispose to refractory headache. Another risk includes those with various central sensitization syndromes. Also, chronic stress can drive the development of refractory headaches. Traumatic brain injury also is another risk, as are psychiatric comorbidities. And another predisposing factor is catastrophizing. Catastrophizing is a major driver of disability. And with catastrophizing does come associated nocebo thinking, which does not help anything. Also, a lack of social support, along with poverty, may contribute to chronic headache. Of course, medication overuse headache. And lastly, prolonged inflammation also may contribute to refractory headache.
When we're talking about risk factors for refractory, that hasn't actually been studied, so we don't know for sure. What has been studied, though, is looking at who is more likely to respond to certain CGRP medications and to onabotulinum toxin. And we also know what puts you at a higher risk for progression of migraine. So typically there we're talking about moving from episodic to chronic. And so if we were to take all of the evidence for those things that have been studied and then make a hypothesis of what likely makes you at risk for refractory migraine, I would say someone who's older age with longer disease duration, though that's probably just because by that point they've gone through so many different treatments. There's some evidence to suggest that it may be a bilateral headache. It might have lost some of its migraine characteristics, like less of that throbbing pain. And in at least one study, there is a difference between the imploding versus the exploding sensation of the headache. So is it internal versus external pressure? That was looked at for an onabotulinum toxin study. Definitely more allodynia. I agree completely with Larry on that one. Medication overuse. But again, is it because of the medication overuse, or is it because that's a marker that they're just not responding, so they need to treat? Obesity may be a marker. Definitely having lots of comorbidities may be a marker. Having more stressors, more depression, more anxiety, more pain catastrophizing, those all seem to be things that can be markers for more likely to have a refractory case. In at least one study, I think it was for onabotulinum toxin, they also looked at having personality disorder traits from type C had some association. And then otherwise, we don't really know a whole lot about the genomics. There's a lot that we need to study. We know there's a whole bunch of loci that are associated with migraine. That's a whole area ripe for research in terms of what makes you more likely to fall into this group. We don't really know much about the biochemistry. So we don't know if you go and measure different levels of various chemicals like we have for progression from episodic to chronic or for various responders. We don't know what that looks like. And we definitely don't know really what the neuroimaging looks like. So multiple areas that are just completely naive to really research in this area.
Great. So why don't we also focus about the headache medicine provider or the neurologist that sees many of these patients. And sometimes we feed off positive outcomes. I think we're all human here. And so let's talk about how to maintain wellness and prevent burnout in the setting of managing maybe a large group of refractory patients in clinical practice.
The hardest part about taking care of patients with refractory migraine is that time and time again, you try something, they come back and say 3 months, and they're exactly the same. They get discouraged, and it's easy for you to get discouraged. We have to remember what our role is for these patients, though. If you remember when they first came to see you, that first appointment, and they were in awe that you listened to them, they weren't stigmatized, you had ideas, and you were going to help them, and at no point have you given up on them, that's part of your role. And you have to remember that if it wasn't for you, a lot of these patients would see physician after physician who would say, there's nothing left. And they would get discouraged and disheartened and would just feel like the medical system's not there for them. And so your role is to be that support. And so if you can try to find the positive in what you're doing, that really helps to prevent you from getting into that burnout stage, because it is hard. It's hard to feel like you just keep failing. And it's not that you're failing. It's that we don't have the right treatments for these patients. You keep hoping and finding that maybe in the meantime, you'll get them on something that will work. But in some ways, we're passing the time until there's new treatment targets.
I think that's a great point. And I know also, Jennifer, you do a lot of advocacy work. So in addition to the listening is just kind of being an advocate for our patients.
And I think also naming it. These patients feel validated when you recognize that what they're going through, it's different. It's something that's not necessarily unique to them. So they're not alone in this, but this is a real phenomenon. They're not making up how difficult it's been. And it really is that they're not responding, and it's not that they've done anything wrong. So I think that's just a very important part, is to validate their journey.
So I think that we as providers have to watch our own burnout and mental health. Some of the refractory patients can be emotionally taxing, and I do find telephone consults somewhat less stressful than when somebody's in the office. I usually say we only have so many emotional marbles for our day. We're going to spend our marbles, and if we spend all our marbles at 8 a.m. with a very difficult patient, we have nothing left to give. So recognizing and managing patients with moderate to severe personality disorders of the difficult types, antisocial, borderline, etc., is very important. I have a talk on this, and it's not that we can cure them, but we can help them, we can help the families, and we can help our clinic and protect ourselves too. Approximately, in my guesstimation, 5% of the world, but 5% of refractory chronic migraine fits into the moderate to severe personality disorders, but they really create 95% of our difficulties and problems. And it does contribute to burnout. One other issue is, do we ever give up on a patient? And I think there's no right or wrong answer. I tend not to, because we are end of the line, and patients feel abandoned. They feel lost, even if nothing is working for 30 years. I have patients for decades where maybe meds are working 20% or 25%, but the relationship means quite a bit to them. I do tend, just like patients with Alzheimer's and the significant other, the caretaker, I do address the caretaker, because taking care of somebody with severe pain and or depression is just not easy. So I think that these are other issues that we don't talk about very much, but we see and deal with every day.
What areas do you feel we really need to focus on in terms of research in this area?
So we've moved along with our definition, and I think that we'll continue to work with. Regarding pathophysiology of refractory chronic migraine, most of the good studies have focused on very interesting MRI and functional MRI studies, and there are a number of differences that have been found in the brain. I think that in the future, the search for biomarkers for every neurologic disease is the holy grail, to find easy biomarkers, not just CSF, but if we could find even functional MRI, but regular MRI biomarkers, it would be terrific. New MRI software holds great promise. Even saliva biomarkers would be helpful. So more MRI and functional MRI studies need to be done. And we haven't done very many studies on treatment. There's almost nothing on label for refractory chronic migraine. So that would be terrific if we could advance it along those lines. We'd also like to look at new mechanisms of action, such as PACAP and possibly even psychedelics.
Great. Well, I think that was an amazing conversation and summary from thinking about the current classification of refractory headache to what it could be, thinking about some of the comorbidity burdens, how best to treat these patients, both with standard of care, some of the barriers there, and some clinical pearls from both of you. I really appreciate this conversation.
Well, it's definitely a topic that I think we're both quite passionate about. So I know I've enjoyed talking about it all with you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.